Welcome to Medical Matters Weekly with Dr. Trey Dobson, presented by Southwestern Vermont Healthcare and Catamount Access Television.
Welcome, everybody. Today is March 23rd, 2022. I think well into spring, or at least it feels like it outside yesterday and today. I'm Trey Dobson, Chief Medical Officer at Southwestern Vermont Medical Center and an emergency medicine physician with Dartmouth Hitchcock Health. And this is Medical Matters Weekly. It's a show about the aspects of healthcare that matter to you most. And my guest today is Tracy Dolan. She is the director of the Vermont Refugee Office. Thank you so much for joining us, Tracy.
Thanks. I'm happy to be here, Trey.
I actually stumbled over that. Vermont Refugee Office. So what's your exact title?
I'm the director of the State Refugee Office. So Vermont's Refugee Office is fine.
That's great. Okay. And just a little bit, we're going to delve into that, which is why Tracy is here. A little bit about her background. She earned a bachelor's in public health education and promotion from, now I'm not going to pronounce this right, Dalhousie
in Halifax, Nova Scotia.
That was close, Dalhousie. Okay. And then a master's in community health and preventive medicine from the University of Northern British Columbia. Got her start, and I want to talk a little bit about this upcoming, in Northern Canada, working with vulnerable populations in reducing the risk of HIV transmission and infection. Spent 10 years working in international health, primarily in, according to my notes here, sub-Saharan Africa with a focus on HIV and AIDS care and prevention, maternal child health, and youth reproductive health. Gosh, you've done quite a bit, Tracy.
It's been a good life.
Other locations. Yeah, that's great. And other locations. So we'll tie all that in. And then you also, most recently, in the way that many of us, including myself, have gotten to know Tracy, is she served as Vermont's Deputy Commissioner of Public Health for 10 years. And most recently throughout all of the COVID pandemic response initiatives. That's where you heard her, where you saw her, and you read about her most recently. So I'll just start by asking this background questions, Tracy. So tell us a little bit about, where you're from and where you grew up and eventually how you ended up here.
Sure, yeah. I was actually born in Newfoundland. So I'm on the right side of the country now. I was born in Newfoundland, and I was there until I was in elementary school. And I came from a big family, a big Catholic family of 6 kids. And so we all got on the plane and moved to British Columbia when my father was working for a pulp and paper company in Newfoundland, and it closed down. And so we were all shifted over to British Columbia, where he found work there. And so Prince Rupert, British Columbia, a small fishing town on the northwest coast, grew up there with my brothers and sisters and my parents. A rainy town, the rainiest place that's inhabited in North America, to be more clear.
Wow.
Yes,
wow.
Very rainy, but a great town. And then eventually went on and went to school for years and years and years because I liked going to school. So I went to University of British Columbia for a few years. I went overseas to Japan for a couple of years after that, worked teaching English there, worked for Radio Japan for a couple of years. I thought I wanted to be a broadcast journalist, so that was part of it. And then traveled a little, came back to Canada, saw some things when I was traveling that inspired my desire to actually go into international work and public health. I thought I wanted to go to medical school, and when I traveled, I sort of got a different sense of where I wanted my efforts to go. I did another undergraduate degree in health education, and eventually ended up doing graduate work up in northern British Columbia, primarily working with our Indigenous population. In British Columbia, we call it First Nations. And so working with First Nations communities around HIV, AIDS, prevention, sexual reproductive health, those kinds of issues. Worked with street-involved youth as well. And then eventually shifted into the international work, went with Save the Children to Malawi in Southern Africa. Malawi, made famous by Madonna, who I believe adopted children from Malawi, and worked a lot on the HIV pandemic, which was, of course, still raging at that time. That was in the late 90s, and doing a lot of work with communities. The goal being in that work to really work with communities on their own prevention and mitigation, trying to support their own structures to do that. And then worked for Child Fund International for a lot of years traveling all around, based in Richmond, Virginia, but working all over the place, Uganda, Zambia, Ethiopia, a lot of different parts of Africa. And then I was the public health HIV senior officer for Child Fund International. So I kind of went wherever there was HIV in the world where we had operations. So some work in India, Central and South America. And then we also responded to emergencies. So actually shifted to some child protection work, and landed in Afghanistan at one point as well. So all over the place. Eventually getting here to Vermont, I actually met my, I will call him my husband. He is my ex-husband, but we think husband sounds better. So I met him and eventually came here to the US, got my green card, my citizenship, and got this lovely job at the health department, eventually promoted into the deputy commissioner there, and have had a great life here in Vermont.
Well, I mean, I know if the audience is anything like I am, I mean, I just envisioned all of this starting with you growing up on the coastline. It was a gray, rainy day, and you had a boat, and you're trying to get out there and fish, to all of the travels eventually in Japan. And I can't wait to read the book when it comes out. So interesting. Let me just ask a little bit, in my medical career, I just sort of missed the HIV. I was in training right when when AIDS was, of course, still around, still something we have to be very careful about. But right when I was finishing, our wards were still, the internal medicine wards were still full, at least half to 3/4 of HIV patients, AIDS patients, which now it dwindled pretty quickly. But I imagine that left a remarkable imprint on you, perhaps more than anything you've done. I don't know. Let me ask you that.
Yeah, I mean, well, and as you know, the HIV epidemic really devastated many regions of the world, and many family structures. I mean, sub-Saharan Africa particularly was brutally hit by HIV, as were parts of India. Whole classes were hit as well. In India, a lot of people among the lower class, people who worked in the sex trade, I mean, just, incredibly hit. But in southern sub-Saharan Africa, the family structures, there were whole generations where grandparents were raising children. I mean, over and over and over, you would go out to places, see all these little kids and see all of these older people raising them. And sometimes, up to 30 or 40% of the middle section who should have been parents were dead. It was brutal. And so it was this large orphan crisis and, of course, health crisis. It impacted every aspect. I remember being in Malawi and finding out, the lifespan had been going up at that point in all over Africa and in many developing countries, and particularly in sub-Saharan Africa. You saw almost a 10-year drop in lifespan among men pretty quickly due to the HIV epidemic. And now, of course, a lot of things that have happened around the UN goals, around eradication of poverty, around hunger, malaria, other things have shifted those numbers back to a better place. But it did have a huge impact, and it's devastating. And one thing that I've learned and relearned is that the idea that we attach any kind of morality to public health and behavior and what makes things happen is laughable, because that's not how disease operates. They don't care what you think is right or wrong. There's simply a situation, and we need to address it. And throwing morality or judgment into the mix when you see whole populations being devastated is just not helpful. And I know morality was heavily tied to HIV here in the US for a long time, and just seeing how unhelpful that is when you're trying to battle something.
Absolutely. And we have to keep talking about it, Tracy, even during COVID. We have to keep talking about for awareness. And actually, we check ourselves, right? We check to make sure that what we're doing and everything is recognizing, yes, there are certain behaviors or certain populations that are going to be at higher risk for illness. And why is that? And let's address those issues, not the judgmental. And I'm so happy you brought that up. Back to Africa and some of your experiences there. You're talking about lifespans. I imagine that the lifespans were rising prior to AIDS. secondary to better treatment for malaria, polio eradication, and then also just supportive clean water, for
Yes.
example. And then AIDS just shot that back so much. We're not seeing quite that effect of COVID in Africa, at least what I'm reading, but it's also early in the in this infectious disease entity of COVID-19. Do you keep up with Africa as far as infectious disease?
I do a little bit. I'm pretty close to Dr. Chen, who was our former health commissioner, and his wife has done work more recently in Uganda. And he actually went over a few years ago and helped set up the first emergency medical school in Uganda, the first emergency medical physicians training program. And so through him, I sort of have been a little more interested in what's going on in Uganda, and I live there a little bit. So I did start to see when it was starting to pick up there, but it has been interesting. I don't know if they're just going to get a miss on this in terms of the broad impact. I don't know if the health infrastructure is so weak that maybe we're not getting accurate reports, or if there's just a lag. I mean, 2 years feels like a forever to us here, but there are some waves of illness that occur, or epidemics or infections or new diseases that occur in one area that might take years to really show up in another. So I'm not certain what's happening there. Wow, we are all learning so much about infection and all of this through this, because a lot of things that we thought we knew, we're learning new things.
No, absolutely. You're right. I mean, when I was reading most recently, I think it was even within the past week, about some of the death rates in Africa being less than other parts of the world. I want to believe that, right? I have that hopeful, but that's a bias. And the truth of the matter is, it's too early to know whether that's a real effect or a reporting effect, like you said, or just a pattern of infectious disease taking hold and the way it's going to present itself. So back to, let's talk about COVID-19 real quick, and then we'll be done with it. You served in this position for the past 2 years. You were really out there in front of the public, helping explain things. And again, thank you for everything you and your colleagues have done. Thank you from Southern Vermont, but thank you from all of healthcare. Tell us a little bit about that experience. I mean, you could talk for hours, right? And you probably don't want to, but just tell us some memorable things you can come up with over the past 2 years.
I think the first thing that I have to share is that when you thank me, I am passing that on in my mind immediately to the staff at the Department of Health, because I was out front, but I was the least of the effort that went into this. I mean, for every hour I put in, there were people putting in 1.5 to 2 hours for every hour. I mean, it was a phenomenal workload. But speaking of things that we didn't expect, normally when we have a public health emergency, we stand up a health operations center, and really most big public health emergencies like this, we plan, maybe 4 months max. They kind of have a natural progression, and none of us thought we'd be standing this up for this long. So I think the shock just to the workforce, and then of course the impact on Vermonters in those early days, I would say one of the hardest things was seeing this spread through the nursing homes, the homes for the elderly. I'm not getting the phrase right, but and seeing it move through, watching people get sick, not having a vaccine yet, not having a cure, of course, and knowing that we were going to see people die from this and not being able to do a whole lot about it. We got out ahead. We worked to increase any kind of infection prevention we could. Vermont was actually #1 in our ability to try to get in early, but even then, that was brutal. And so the impact on our elderly, I know it hit everybody, but I have to say the impact on our elderly around isolation, dying alone, and then all of and then our staff that were working with those nursing homes, and working with the staff there at 2:00 in the morning, and having our public health people and the nurses talk, and the sense of helplessness. That is, that just can't be forgotten. The impact that has on people to do all of that work, to be so close, and to sometimes feel helpless. So I feel like we've come so far in that we have vaccines that can help us, especially with hospitalization, preventing hospitalization and death. But it was an incredible experience. Worked with incredible people. People had to step up in every area, including in healthcare, and go beyond what they thought they had ever would do, learning new skills and having to be so incredibly flexible. Working in developing countries, I'm used to the idea that, we might work with almost nothing at times. We are not used to that here. So to actually have to work with serious resource shortages, not only people, but equipment and information and medicine, that's new. It was hard. And Vermont stepped up and was amazing across the board, all the way from communities, kids, teachers, healthcare. I mean, so much kudos to healthcare, public health staff, companies, businesses. I mean, just everyone. It's been an incredible experience, and I'm so honored to have been part of it through last year.
You talk about these congregate living situations like the skilled nursing facilities and the assisted living, and it almost, in watching people die, that probably is quite similar to some of the HIV and AIDS work that you were doing. But you just remind me of something, even during that part, just a year and a half ago, there's a lot of judgment, unintentional placed. So an outbreak would occur, and it was, pretty quickly because what did they do wrong? What did they do? And it took us a while to understand you can do everything right. You can follow the books, and it's no one's fault, but the infectious disease, it's going to win out. We have to keep working on the prevention and treatment, not some, complete avoidance, because we can't avoid infectious disease. If we could avoid it, then it wouldn't be a pandemic, right? That's the whole aspect. So let's talk some about your work now, because it's exciting, it's different. I guess my first question is, how did you make that leap?
Yeah, it has been really exciting. Yeah, no, and I did love my previous job, but coming into this, I mean, there was an opportunity. When you work in state government, when you work as a governor appointee, at some point you're probably going to have to shift out, because governors shift out, and eventually you probably have to make that change. So it's nice to get out ahead of it and make the change into a place that you'd like to go. Sometimes people in these types of appointed positions, if the governor changes and their position has to change, they kind of look and see what's available and take what's available at times. And sometimes they leave state government. I really like working for the state of Vermont. It's been great for me. So to see this position open up, to know that there was a lot of interest in it, to know that we had a governor who was particularly interested in it. Not that I'm saying former governors haven't been, but this governor early on, well before the Afghanistan situation, was really vocal about having a pretty strong interest in refugees, and also really vocal through the COVID response too, about a really strong interest in equity in the state overall, and those kinds of issues. So I thought it was a really good opportunity. So we had a great state refugee director, Delise Lamoureux, who was in this position for about 20 years. And so I knew I was stepping into something that was strong. And then, of course, within a couple of weeks, the Afghanistan situation happens. And so it has been, and it continues to be, a lot of learning. And it's been great. It's been intense, not in the same way of the pandemic, probably a little more positive, but it's been intense and great.
Let me ask some just really obvious questions that you may or may not be able to answer, almost cliche, like how many Afghan refugees have we seen in Vermont, and do we anticipate more?
Yes, we have right now about 240, I think. And we anticipate that we will likely see, we're ready to take up to about 130 more. Not sure if we will get all of those. So we had phase one. So they started arriving in kind of October, November. They kept coming all the way through mid-February. And now we're likely going to see phase two start sometime in April through June. So we will see another wave of Afghan arrivals coming in, and so far it's been very good.
And for the audience, just to know, I'm sure all hospitals have participated in healthcare systems and trying to provide some healthcare for these individuals. I know we were contacted and able to get some primary care and follow-up care for these individuals. And also, Tracy, I mean, I don't know where I heard this. I read something that there are groups of Afghans still waiting in Washington, D.C. to be relocated. Is that this phase two that you're talking about?
Yeah, there were Afghans waiting. So there were kind of military bases where folks were, and that's where they were getting released from. They closed all of them down. Maybe they have one that's open, but there shouldn't be many in that situation. Now, where we've got people coming from is people who are waiting in other countries to come into the U.S. Qatar, as an example, and so they'll be coming in, making their first stop somewhere, probably in a central military. A base or some central welcome area, and then being sent to communities. And so now we'll have those folks coming in as phase 2.
Okay, that's great. Tell me, let's focus a little bit just on the healthcare aspect, because I know you were in charge of all aspects, but what do you see these refugees needing? And I'm sure it varies from what part of the world they're coming from.
It does. And, I just want to shout out that up until this year, most of our refugees were coming in through the Chittenden County area. So the UVM system did a lot of support for them. And what has happened this year very quickly is that all kinds of other hospitals and primary care providers all around the state, because Afghans are going to a lot of different places, have had to stand up, and they have just been exceptional with very little orientation or training or support. They've suddenly had to figure it out. The kinds of things we're seeing, we're seeing some gastrointestinal issues with folks coming in. A lot of that could be stress induced. It could be also change in diet and situation. We are seeing, we know through our lead program, we're seeing elevated lead programs in kids, lead levels in kids, some lead poisoning there. That's probably likely related to cookware that was used back in Afghanistan, also possibly related to some cultural practices like the use of a particular type of eyeliner that is given to small children culturally that may have some lead in it as well. And then we're seeing a lot of dental issues. A lot of folks come, not just from Afghanistan, but from a lot of countries where we receive refugees that certainly didn't have any regular dental care. So those needs are here. And then all the other needs that you would have probably in any population. Some of these folks probably never had any kind of regular medical care unless they were very sick, whereas some of them may have had regular medical care because they may have been more middle class.
Right. Yeah, it's funny from an emergency medicine standpoint, we study diseases that are international, and that's the first thing I think about are these, more rare cysticercosis and leishmaniasis and all these things that, we screen for. I do know they screen for them right when they come in because we've done some of that screening. But then after that, it's the same health concerns we all have, really, like you said, related to what your education level is typically and what your economic level is. And I'm glad that Southern Vermont's been participating. I think the whole state has been participating. It's great. I know the next question from the audience is going to be, what about Ukraine? Are we going to be seeing any refugees from Ukraine? And I'm sure you don't have a crystal ball there, but what are you seeing so far?
So up until today, the message we had been getting was, and I think this is still primarily the message, the goal is, and as you know, millions leaving Ukraine right now. I keep saying the Ukraine because old school, that's how we learned it, but it's actually Ukraine. The Ukraine is associated with the Soviet Union and Russia, so it's Ukraine. So we are seeing people, millions leave Ukraine. The goal is to keep them in the EU area, European Union area. They have, of course, the ability to move as part of the European Union when they're there freely, with the goal, of course, that they get resettled back into Ukraine when peace is found. But there are millions and millions, and there's a lot of pressure here in the U.S., especially with people who have Ukraine families here who have members over there to try to bring them in. Generally, we're still hearing that there's probably not going to be a mass refugee resettlement. Refugee resettlement usually takes years and years. Afghanistan was an exception because the U.S. airlifted a lot of people out. They felt a very strong moral obligation because so many were helping the military. In the case of Ukraine, we may still have some exceptions here. Obviously, the geopolitical implications of this war are tremendous. Obviously, the scope is huge with that many people leaving. But what we're starting to hear now is that maybe there will be an opportunity, if there are families here, that they may be able to bring in family members as refugees. We have received no formal guidance. So right now, we're not really preparing, and we haven't been told to prepare. But normally the way refugee resettlement works is that the State Department actually assigns refugee families to refugee settlement agencies. across the country, and that's how it works. So it doesn't really happen one-on-one in that way. So we'll see what happens. We know it could come. We're not sure how big the numbers will be. We know the goal generally is to help where they are in that area in Europe, and not necessarily to bring them all the way over.
Right. Well, they want to be home when they can, I assume. Yeah. And thank you for updating us on that. I mean, it's questions that I have as well, and I really don't know a resource to go read that information that you just told in about 2 minutes. So thank you so much. We have to mention your experience as a comedian, just to shift gears here. So just tell me, I mean, is your favorite show The Marvelous Mrs. Maisel or no?
Oh, you know, I like that show. I liked season 1 the best. My favorite parts of The Marvelous Mrs. Maisel is when she's actually on stage, because I'm a comedian, so I'm curious about her process, you know. But I don't know that that's my favorite. But no, comedy was great during the pandemic as a release, even if it was through Zoom. It's been really exciting to see people actually be able to get on a stage again since we're not post-pandemic, but since we've had some relaxing of the rules, and since so many people were vaccinated, of course. Got to shout out the Vermont Comedy Club has done an amazing job of ensuring that they have audiences that are vaccinated and masked. But yeah, it's a nice release. It's a wonderful comedy community here, and if anyone ever wants to try it out, they should look into taking a class or come out to an open mic. It's you know, all parts of your health are important, including your social and mental health, and sometimes laughing helps.
Is that what you did? Did you take a class, or how did you get into it?
Well, I didn't actually, but a lot of people do. I actually taught a class, and so my class just finished a few weeks ago. But I actually got into it. A colleague in state government had gone to a few open mics years ago and said, "Why don't you come out and check one out?" So I came out and I listened, and I thought, "Oh, maybe I could do that." And so I went back the next week. This was, you know, probably 7 or 8 years ago. And that's how I got into it. Just started going to some open mics, and you get up and you tell a funny story that you've told at parties that you've noticed that people laugh about, and then you build from there.
No, that's so awesome. Does it affect or how does it affect your healthcare work, or does it? Probably indirectly, but how do you tie those together?
Yeah, well, you know, right now I don't do healthcare work, so I'm the refugee director, but yeah. I will say, how does it affect my work? I've always kind of joked around a little bit at work, so that remains. I think it just gives me an outlet so that if something is hard, you know, I don't talk about the specifics of work on stage, but I might be able to work through something by changing some of the details or changing the context. And it's a fun way to connect with people. I've had people, when I was deputy commissioner, you know, it can be a little hierarchical, but then if they see you at the comedy club, then they feel a connection to you. And so that's also nice. And I think bringing humor into the workplace is almost always helpful. I'm hoping, you know, with the refugee program, I've talked to the comedy club. They would love to figure out how to do some workshops for new Vermonters who want to, you know, get into a little comedy. So I think anything to lighten up the time that we have on this planet is time well spent.
That's awesome. I mean, humor definitely improves familiarity, as you mentioned, among individuals, and familiarity is what breeds trust, right? And so that's really, I think, important in the workforce. Thank you so much for joining us today, Tracy. It's just been awesome.
Thank you. It was really great to talk to you.
All right. So let's see here. Thanks everyone for coming and viewing or participating with Medical Matters Weekly. I'll also thank Mike Cutler of CAT TV, Ray Smith from Southwestern Vermont Healthcare, Ashley Jowett from Southwestern Vermont Healthcare. I'm Trey Dobson. Go out and find joy in everything you do, even in the face of adversity, and we will see you next week.